15. Nausea and vomiting. Arvind Rengarajan, C. Prakash Gwala. Nausea is an unpleasant subjective sensation of impending vomiting and can be associated with salivation, anorexia, perspiration, disinterest in ongoing activities, and anxiety. 1. In many cases, the sensation cannot be localized, although in some instances, it is felt in the epigastrium or throat. Nausea typically occurs preceding or during vomiting but can happen in isolation. Retching or dry heaving consists of spasmodic respiratory movements with the glottis closed. When part of the emetic sequence, retching is associated with intense nausea and usually, but not invariably, culminates in the act of vomiting. Vomiting or emesis is a partially voluntary act of forcefully expelling gastric or intestinal content through the mouth. This can occur in isolation but is often part of the emetic sequence that includes nausea and retching and requires central neurogenic coordination. Vomiting must be differentiated from regurgitation, the effortless reflux of gastric contents into the esophagus that sometimes reaches the mouth but without the forceful ejection typical of vomiting. See Chapter 13. Regurgitation can be esophageal, whereby the regurgitate tastes exactly like recently eaten food, or gastric, whereby the regurgitate tastes sour and may be associated with burning. Esophageal regurgitation can occur in disorders associated with esophageal outflow obstruction, such as achalasia. 2. By contrast, gastric regurgitation can occur with GERD3 or rumination syndrome, a behavioral disorder. See Chapter 13. 4. The differential diagnosis of vomiting needs to be kept in mind because patients often report vomiting without distinction, and a detailed clinical history is needed to distinguish regurgitation from vomiting. Pathophysiology. The mechanism of vomiting requires synchronized contraction and/or relaxation of several muscles, including the diaphragm, abdominal wall muscles, pharyngeal muscles, and muscles responsible for breathing, as well as postural changes to accommodate oral emptying of stomach contents. Fig. 15.1.1. 5 to 7. Although a network of neurons in the brainstem controls the motor elements of the emetic response, important neural circuits in the medulla initiate vomiting. 8. Afferent neural signals for initiating emesis arise from many locations in the body including the pharynx, stomach, and small intestine, as well as from extra-intestinal organs like the heart and the testicle. Abdominal pain by itself can be a trigger for initiation of nausea and vomiting. 7. Pathways from the chemoreceptor trigger zone, CTZ, located in the area post-rema on the floor of the fourth ventricle also activate vomiting. Despite its central location, the CTZ is outside, at least in part, the blood-brain barrier and serves primarily as a sensitive detection apparatus for circulating endogenous and exogenous molecules that may activate emesis. Finally, pathways arising from other CNS structures, including the cortex, brainstem, and vestibular system via the cerebellum, can also initiate symptoms. The perception of nausea requires intact neural circuits in the supratentorial regions. 9, 10 Afferent signals that mediate vomiting are carried by vagal fibers to the nucleus tractus solitarius, but nausea may occur even following bilateral abdominal vagotomy. 11 Indicating the existence of alternative pathways for the development of nausea. Nausea and vomiting therefore only share part of the neural circuitry used to generate these symptoms, which explains why nausea and vomiting are clinically and pharmacologically separable. 11 In some patients, nausea may be present continuously and become quite troublesome. The circuitry of the emetic reflex involves multiple receptors. 7 The following elements are the most relevant to clinical issues: stimulation of brain 5-hydroxytryptamine 3, 5-HT3, serotonin receptors provokes release of dopamine, which in turn stimulates dopamine D2 receptors in the brainstem, thereby activating the emetic sequence. This sequence is the basis for the pharmacodynamic action of antiemetic agents like ondansetron, a 5-HT3 receptor inhibitor that is effective in treating acute, 0 to 24 hours post-drug, chemotherapy-induced vomiting, and metoclopramide, a dopamine D2 receptor antagonist. 12 Toxins and drugs, including chemotherapeutic agents, that act on the GI tract are detected by enteroendocrine cells that release 5-HT, which in turn activates 5-HT3 receptors on vagal afferents. 11 Histamine H1 and muscarinic M1 receptors, which are abundant in the vestibular center and solitary nucleus, constitute the preferred pharmacologic targets for inhibiting motion sickness, vestibular nausea, and pregnancy-related emesis. 13 Cannabinoid CB1 receptors in the dorsal vagal complex inhibit the emetic reflex. 14 Cannabinoid agonists also modulate 5-HT3 ion channels. The CB and 5-HT3 receptor systems co-localize and interact in the brainstem. 15 Activation of somatodendritic 5-HT1A autoreceptors in the dorsal raphe nucleus by cannabinoids reduces nausea and emesis provoked by emetogenic drugs. 16 191 Drugs/chemicals, 5-HT peritoneum vestibular apparatus. Fig. 15.1 Schematic representation of the proposed neural pathways that mediate vomiting. 5-HT 5-hydroxytryptamine. Neurokinin 1, NK1, receptors located in the area postrema and the solitary nucleus bind to substance P and are part of the terminal emetic pathways. Activation of NK1 receptors by substance P constitutes the basis of chemotherapy-induced emesis, i.e., emesis 24 to 72 hours after administration of chemotherapeutic drugs. 12 NK1 antagonists reduce emesis induced by peripherally and centrally acting emetogens. 5-HT3 receptors appear to be involved to a greater extent in centrally induced emesis than in peripherally induced emesis. Therefore, NK1 receptor antagonists appear to be more efficacious than 5-HT3 receptor inhibitors and other known antiemetic drugs in reducing vomiting induced by a variety of causes and are useful in preventing delayed emesis induced by chemotherapeutic agents. 7 Conversely, they may have less potent anti-nausea effects. When activated, the brainstem sets into motion, through neural efferents, the various components of the emetic sequence. See Fig. 15.1. 7 First, nausea develops as a result of activation of the cerebral cortex, the stomach relaxes concomitantly, and antral and intestinal peristalsis is inhibited. Second, retching occurs as a result of activation of spasmodic contractions of the diaphragm and intercostal muscles combined with closure of the glottis. Third, the act of vomiting occurs when somatic and visceral components are activated simultaneously. The components include brisk contraction of the diaphragm and abdominal muscles, relaxation of the lower esophageal sphincter, and a forceful retrograde peristaltic contraction in the jejunum that pushes enteric content in the oral direction. 17 Simultaneously, protective reflexes are activated. The soft palate is raised to prevent gastric content from entering the nasopharynx, respiration is momentarily inhibited, and the glottis is closed to prevent pulmonary aspiration, which is a potentially serious complication of vomiting. Other reflex phenomena that may accompany nausea include hypersalivation, cardiac arrhythmias, and passage of gas and stool rectally. Emesis may alleviate nausea. 7 Clinical characteristics. Certain clinical features may be characteristic of specific causes of nausea and vomiting. Symptoms in the morning or on an empty stomach, with swallowed saliva or gastric secretions in the emesis, suggest direct activation of the brainstem or CDZ, most typical of pregnancy, drugs, toxins, e.g., alcohol, and metabolic disorders, e.g., diabetes mellitus, uremia. Functional vomiting may also exhibit these characteristics. Although excessive nocturnal postnasal drip is thought to demonstrate a similar pattern, direct evidence for this association is lacking. Vomiting of retained and partially digested food beyond the immediate postprandial period is typical of gastroparesis or slowly developing gastric outlet obstruction. 18 Bilious vomiting is commonly seen after multiple and repetitive vomiting episodes because of retrograde entry of intestinal content into the stomach or in the presence of a surgical gastroenteric anastomosis. Vomitus with a feculent odor or taste suggests intestinal obstruction, ileus, long-standing gastric outlet obstruction, or a gastrocolic fistula. Vomiting that develops abruptly without preceding nausea or retching, projectile vomiting, is characteristic of, but not specific for, direct stimulation of the brainstem from an intracerebral lesion, tumor, abscess, or increased intracranial pressure. 19 Causes. Establishing the etiology of nausea and vomiting allows specific management targeting the underlying mechanism. The urgency of diagnostic investigation is determined by the clinical presentation. Aggressive investigation is warranted when vomiting is bilious, when neurologic deficits are present, or if vomiting is acutely worsening. Short-term symptoms, 1 week, should be evaluated urgently, whereas chronic symptoms may be investigated electively in the outpatient setting. Causes of nausea and vomiting are listed in box 15.1. Acute vomiting. In the patient with acute vomiting, the following 2 questions must be answered first. Fig 15.2 is emergent evaluation or management needed. The patient is assessed for shock, dehydration, hypotension, and serious electrolyte disturbances with a carefully taken history and basic laboratory testing, CBC, comprehensive metabolic panel, and serum amylase and lipase levels. Intestinal obstruction, hollow viscous perforation, infectious processes, acute pancreatitis, organ infarction, cerebral edema, acute adrenocortical, Addisonian, crisis, and poisoning are some of the emergent etiologies to be considered. Is the female patient pregnant? In women of reproductive age, pregnancy must be considered and excluded before alternative etiologies are considered. Once these 2 issues are addressed, a number of potentially emergent diagnostic possibilities should be considered. Gastric outlet obstruction. In the past, PUD was a major cause of gastric outlet obstruction, see Chapter 53, resulting from edema due to an active pyloric channel ulcer or stenotic narrowing of the pylorus from prior PUD. Vomiting can develop acutely but can also be chronic and slowly progressive, mimicking gastroparesis, see Chapter 50. Although the incidence of gastric outlet obstruction is not well established in the literature, it has likely decreased with early and effective treatment of PUD, since complicated peptic ulcers are now relatively infrequent. 20 Gastric volvulus and paraesophageal and post-traumatic diaphragmatic hernias are other relatively uncommon but important causes of acute vomiting. Symptoms may be relapsing because of intermittent obstruction and spontaneous resolution, Fig 15.3, see Chapter 27.21. Excessive splenic mobility, i.e., wandering spleen, and outlet obstruction by a box 151. Principal causes of nausea and vomiting: abdominal cardiovascular drugs, congenital malformations, mechanical obstruction, antiarrhythmics, increased intracranial pressure, gastric outlet obstruction, antihypertensives, low pressure hydrocephalus, SBO, calcium channel blockers, intracerebral lesions with edema, motility disorders, digoxin abscess, chronic intestinal pseudo-obstruction, diuretics, hemorrhage. Functional dyspepsia, beta receptor blocking agents, infarction, gastroparesis, CNS drugs, neoplasm. Other intra-abdominal causes: anti-Parkinsonian drugs, levodopa and labyrinthine disorders, acute appendicitis, other dopamine agonists, labyrinthitis, acute cholecystitis, anticonvulsants, Meniere's disease, acute hepatitis, GI medications, motion sickness, acute mesenteric ischemia, azathioprine, meningitis, Crohn's disease, sulfasalazine, migraine, headaches, gastric and duodenal ulcer disease, narcotics, otitis media, pancreatitis and pancreatic neoplasms, oral contraceptives, seizure disorders, peritonitis and peritoneal carcinomatosis, theophylline, visceral neuropathy, retroperitoneal and mesenteric pathology, infectious others, drug *, acute gastroenteritis, anxiety and depression, aspirin and other NSAIDs, viral cannabinoid hyperemesis syndrome, anti-diabetic agents, bacterial cardiac disease, anti-gout drugs, non-GI, systemic infections, heart failure, antimicrobial agents, metabolic and endocrine. Myocardial infarction, ischemia, acyclovir, radiofrequency ablation for arrhythmias, acute intermittent porphyria, antituberculosis drugs, collagen, vascular disorders, Addison disease, erythromycin, scleroderma, diabetic ketoacidosis, sulfonamides, SLE, diabetes mellitus, tetracycline, cyclic vomiting syndrome, hyperparathyroidism and other causes of cancer, chemotherapy, eating disorders, hypercalcemia, cisplatin, ethanol abuse, hyperthyroidism, cytarabine, functional disorders, hyponatremia. Dacarbazine, hypervitaminosis A, hypoparathyroidism, adipocyte, intense pain, pregnancy, 5-fluorouracil, paraneoplastic syndrome, methotrexate, nervous system, postoperative state, nitrogen mustard, demyelinating disorders, post-vagotomy, tamoxifen, disorders of the autonomic nervous system, radiation therapy, vinblastine, hydrocephalus, starvation, * partial list. Pseudopolypoid antral mass, e.g., heterotopic pancreas, are other uncommon but well-described causes of acute vomiting. 22,23 Both acute and chronic pancreatitis, with associated inflammatory masses, necrosis, pseudocysts, or secondary infection, may lead to gastric outlet obstruction at the duodenum or, less commonly, the antrum and pylorus, see chapters 58 and 59. Similarly, gastric, duodenal, or pancreatic malignancies, adenocarcinoma, lymphoma, cystic pancreatic neoplasms, may cause gastric outlet obstruction, sometimes manifesting as acute vomiting, see chapters 32 to 34, 54, 60, and 125. Acute intestinal obstruction vomiting may be a cardinal presenting symptom of intestinal obstruction. The onset and severity are determined by the degree of luminal compromise and the acuity of development of obstruction. Proximal intestinal obstruction may be particularly difficult to diagnose because the obstructing lesion may be overlooked or unreachable by conventional EGD and yet may present without the typical picture of dilated fluid-filled loops of small bowel, air fluid levels, on plain abdominal films, see chapter 123. Distal duodenal and proximal jejunal neoplasms, adenocarcinoma, lymphoma, leiomyosarcoma, carcinoid, may cause gastric outlet or intestinal obstruction that manifests as acute or chronic vomiting. Intestinal infarction may occur with a paucity of physical signs but requires expeditious management, especially in acute arterial mesenteric infarction, because the in-hospital mortality rate is greater than 60%. 24 This diagnosis should be considered in the appropriate clinical setting. 25 Especially in patients with vascular disorders and thrombotic diatheses and in older adults, see chapter 118. Infectious and inflammatory causes. Vomiting is common in acute infectious illness. Norovirus-induced gastroenteritis is a common cause of sporadic or infectious viral illness. 26 Toxin-producing bacteria such as Staphylococcus aureus and others result in enterotoxin stimulation of enterochromaffin cells that release 5-HT and activate vagal afferent pathways to cause vomiting. 27 During the early stages of illness, nausea and vomiting may be the predominant or even exclusive clinical manifestation, see chapters 110 and 111. Systemic infections, septicemia, urosepsis, pneumonia, meningitis, can also result in nausea and vomiting. Intraperitoneal or retroperitoneal inflammatory conditions, e.g., acute appendicitis, acute cholecystitis, peritonitis, acute pancreatitis in general, any cause of acute abdominal pain, may be associated with vomiting. Vomiting is occasionally so intense. Fig 15.2 Algorithm for the management of a patient with acute vomiting. Potential treatments are shown in italics. 5-HT, 5-hydroxytryptamine, and ear, nose, and throat. Fig 15.3 Abdominal film, A. Endoscopic image, B. And CT scan, C. In a patient with an obstructing paraesophageal hernia, P. Presenting with nausea and vomiting. Note the presence of the air-containing viscus in the left thoracic cavity on the imaging studies. On retroflexion in the stomach during EGD, the opening into the paraesophageal hernia is visualized. Emergent surgery was performed to repair the paraesophageal hernia. And rarely, the only symptom, that it causes diagnostic confusion, see chapters 11, 58, and 120. Extraintestinal causes. A primary extraintestinal condition may cause nausea and vomiting. Myocardial infarction may manifest initially as acute vomiting because of afferent connections between the heart and brainstem. Similarly, renal colic, biliary pain, and ovarian or testicular torsion may manifest with intense vomiting, although localization of the pain and other characteristic features usually make these diagnoses evident, see chapter 65. Medications and toxins. The list of medications that can induce nausea and vomiting is lengthy, and both nausea and vomiting are frequent side effects attributed to many medications in common use, see box 15.1. Common culprits include NSAIDs, cardiovascular drugs, digitalis, antiarrhythmics, antibiotics, levodopa and its derivatives, theophylline, opiates, and azathioprine. Patients on multi-drug regimens pose a special challenge in identifying the culprit drug. Alcohol abuse, medication overdose, and acute poisoning can also cause nausea and vomiting. Cancer chemotherapy is associated with a high likelihood of nausea and vomiting, and prophylactic antiemetic therapy is routine. Chemotherapeutic agent combinations vary in their propensity to cause nausea and vomiting, and patient-related factors also contribute. See box 15.1.28. As many as 50% to 80% of patients undergoing radiotherapy may experience nausea and vomiting, depending on the site of irradiation, patient's susceptibility, and radiotherapy protocol. 29 Metabolic causes. Practically any electrolyte disturbance can cause nausea and vomiting, including but not limited to uremia, hypercalcemia, hyponatremia, and both hypoglycemia and hyperglycemia. Diabetic ketoacidosis, hypoaldosteronism, Addison disease, hyponatremia, and hypercalcemia have a particular propensity to be associated with nausea and vomiting. Diabetes mellitus can also cause nausea and vomiting through development of gastroparesis. Correction of the underlying process will typically lead to resolution of nausea and vomiting. Neurologic causes. Nausea and vomiting associated with motion sickness involves stimulation of 5-HT1B and 5-HT1D receptors expressed in the vestibular apparatus. 30 Meningeal inflammation or meningitis can manifest as nausea and vomiting as the sole or predominant manifestation. Nausea and vomiting may be associated with vertigo in patients with vestibular or cerebellar disorders. Intracerebral lesions associated with increased intracranial pressure, interference with intracerebral fluid flow, or direct compression of the brainstem may manifest with nausea and vomiting, sometimes projectile. Migraine headaches may be accompanied by nausea and vomiting with little or no headache, making the diagnosis difficult. Ictal vomiting is an uncommon manifestation, most often associated with right temporal lobe epilepsy. 31 A rare autoimmune condition associated with antibodies against a brain water channel may cause severe nausea and vomiting. 32 Exercise-induced nausea and vomiting may provide a clue to the diagnosis of pheochromocytoma or paraganglioma. Postoperative nausea and vomiting. Up to 43% of patients undergoing surgery who do not receive prophylactic antiemetic therapy will experience nausea and vomiting after surgery, one of the more common morbidities associated with surgical procedures. Numerous factors play a causative role, including age, gender, time since the last meal, type of anesthesia, and type of surgery. The risk is highest with abdominal, gynecologic, eye, and middle ear surgery and is 3 times as common in women as in men. 33 General and epidural anesthesia carry the highest risk, whereas the risk is much lower for anesthesia. 34-35 The differential diagnosis of postoperative nausea and vomiting includes complications of surgery, intestinal perforation, peritonitis, electrolyte disturbances, and cardiac disease, silent myocardial infarction, heart failure. Chronic or relapsing vomiting. The same causes of acute vomiting discussed earlier must also be considered in patients with chronic vomiting, but with specific features as discussed later. Other etiologies for relapsing vomiting include pregnancy, functional vomiting, cyclic vomiting syndrome, CVS, intermittent partial bowel obstruction, and hereditary angioedema. Partial intestinal obstruction. Although complete intestinal obstruction manifests with the acute onset of abdominal symptoms that prompt urgent evaluation, partial intestinal obstruction may present with relapsing vomiting that waxes and wanes as intestinal transit is intermittently interrupted and spontaneously restored. Stricturing Crohn disease, neoplasms of the intestine, radiation enteritis, and ischemic strictures are the main identifiable causes of partial mechanical intestinal obstruction. See chapters 41, 115, 118, and 123. Intermittent or chronic gastric outlet obstruction from PUD was an additional potential cause in the past, but this diagnosis is relatively infrequent in modern times. Adhesions from surgery or pelvic inflammatory disease can cause intermittent bowel obstruction, but establishing their pathogenic role is sometimes difficult. Advanced intra-abdominal cancer is another cause of intestinal obstruction. Long-standing partial intestinal obstruction can mimic chronic intestinal pseudo-obstruction, and indeed, occult partial intestinal obstruction needs to be excluded before a diagnosis of pseudo-obstruction can be made. See chapters 123 and 124. In older, debilitated individuals, particularly with psychiatric comorbidities. Constipation and obstipation may lead to a presentation similar to intestinal obstruction when the colon becomes impacted with stool and ileal outflow is partially impeded. See Chapter 19. 36 GI motility disorders. Gastroparesis and chronic intestinal pseudo-obstruction may produce chronic vomiting. See Chapter 50. 37-38 Recurrent or chronic vomiting is the presenting manifestation of gastroparesis, but a similar presentation can be seen with functional dyspepsia, chronic functional nausea and vomiting, and CVS, in which clear symptom-free periods are interspersed between stereotypical symptom episodes. See later. 37-39-40 Vomiting in gastroparesis and functional disorders may lead to food aversion, poor oral intake, trace nutrient and vitamin deficiencies, and malnutrition. 41 The stomach may become dilated, and the vomitus may contain partially digested food, but these findings are not constant. Marked gastric stasis tends to be associated with more severe vomiting and early satiety. 42 Although delayed gastric emptying is the hallmark of gastroparesis, gastric emptying can also be delayed in functional dyspepsia, and the degree of emptying delay may not necessarily predict negative health outcomes or refractoriness to therapy. 43-45 Diminished accommodation of the proximal stomach can explain some of the symptomatology in gastroparesis. 46 And decreasing gastric stasis may improve symptoms. 47 Diabetes mellitus is a major cause of gastroparesis. 48 In which cellular abnormalities such as loss of growth factors for the interstitial cells of Cajal, which generate pacemaker activity, enteric nerve abnormalities, and increased immune cells have been reported. 42-49-51 Iatrogenic gastroparesis may occur in patients with diabetes mellitus treated with incretins, pramlintide or exenatide. 48 Idiopathic gastroparesis can develop after an acute viral, e.g., CMV, EBV, illness, in which abdominal pain may be a prominent feature. 42-52-54 Demyelination, similar to that found in Guillain-Barré syndrome, has been observed. 55 Post-viral gastroparesis is often self-limited. 53 Chronic gastroparesis with recurrent nausea and vomiting can be observed transiently or chronically after fundoplication for GERD or after bariatric surgery and arises mainly from altered gastric accommodation, although vagal injury may contribute. See Chapters 8 and 46. 56 Gastroparesis may also develop after pulmonary or combined heart-lung transplantation. 57-58 Chronic nausea and vomiting, clinically indistinguishable from idiopathic gastroparesis but with normal gastric emptying, has been described. 51-59 Intestinal pseudo-obstruction can manifest with nausea and vomiting in addition to abdominal pain and distension and is characterized by partial or complete intestinal obstruction in the absence of a restricting or occlusive luminal lesion. See Chapter 124. 60 The distinction between gastroparesis and chronic intestinal pseudo-obstruction often requires specific diagnostic tests. Chapters 50 and 124. Neurologic disorders. Neurologic disorders are an important and sometimes diagnostically elusive cause of chronic nausea and vomiting. Migraine, particularly atypical forms without an aura or family history and with delayed or no headache, is an important neurologic cause of chronic or relapsing vomiting. CVS and abdominal migraine are thought to represent migrainoid disorders. See later. Hydrocephalus and lesions that compress or irritate the base of the brain may also account for chronic vomiting. Nausea and vomiting during pregnancy. Both nausea and vomiting are commonly experienced during pregnancy, with a frequency between 50% and 80%. 61 These symptoms tend to develop early in pregnancy, peak around 6 to 12 weeks gestation, and rarely continue beyond 22 weeks gestation. Although nausea and vomiting tend to occur more often in the morning, hence the designation morning sickness, symptoms can occur at any time of day. Symptoms may start before a woman realizes she is pregnant, therefore, a pregnancy test should be administered in any fertile woman with a new complaint of nausea and vomiting. Although morning nausea and vomiting may be regarded as a normal manifestation of pregnancy, excessive or severe symptoms may warrant pharmacotherapy. The pathogenesis of nausea and vomiting during pregnancy remains unclear, although hormonal and psychological influences are thought to contribute. Risk factors include multiple gestation, underlying GERD, younger age, and first pregnancy. Whereas estrogen and progesterone have been thought to slow gastric emptying, increased HCG levels during the first trimester may stimulate gastric CCK receptors and trigger symptoms. Higher HCG levels, as seen in molar pregnancies and multiparity, have been associated with more frequent nausea and vomiting. 62,63 Hyperemesis gravidarum. Hyperemesis gravidarum refers to severe and persistent vomiting that leads to complications and occurs in 0.3% to 3% of pregnant women. Maternal complications include weight loss of more than 5% of prepregnancy weight, electrolyte imbalance, dehydration, ketosis, and Mallory-Weiss tears. Hyperemesis gravidarum is more common among young, primiparous mothers, especially of Asian and Middle Eastern ethnicities. 64 A variety of nutritional deficiencies have been reported as a consequence of severe emesis, including deficiencies of B vitamins and fat-soluble vitamins. Disturbances in serum electrolytes can result in profound hypokalemia. The psychosocial burden of hyperemesis includes fear of subsequent pregnancy. 65 Fetal outcomes have been less well described, with higher rates of low birth weight and preterm delivery in infants born to women with hyperemesis gravidarum. 66 Hyperemesis gravidarum is the most common cause of hospitalization during the first half of pregnancy in the U.S., second only to preterm labor. 67 Exclusion of alternative pathologic causes of nausea and vomiting, such as PUD, cholecystitis, appendicitis, pyelonephritis, is essential before a diagnosis of hyperemesis gravidarum is made. Initial laboratory testing includes CBC, comprehensive metabolic panel, thyroid function studies, serum lipase levels, urinalysis for ketones, and a serum beta-HCG level for evaluation of possible molar and multiple gestations. Hyperemesis gravidarum is often associated with failure to respond to outpatient management and often requires hospitalization for fluid and electrolyte replacement therapy and parenteral antiemetics. Simple lifestyle changes including eating frequent, small meals, avoiding known dietary triggers and strong odors, and utilizing over-the-counter remedies such as ginger, pyridoxine, vitamin B6, and acupressure wristbands or acupuncture are first-line therapies. Randomized trials show benefit with use of ginger extract compared with placebo, regardless of ginger dose or preparation. 68-71 Pyridoxine and acupressure, P6 pressure point, can provide symptomatic benefit. 72-74 Second-line treatments include antiemetic medications, for fluids, and repletion of electrolytes. Dopamine antagonists improve symptoms as well as serotonin antagonists, but with a higher likelihood of adverse effects, particularly for metoclopramide. 75-76 Advanced management of refractory cases may include glucocorticoids and enteral feeding when symptoms are severe and life-threatening. 77-78 Functional vomiting. Population-based data indicate that vomiting that occurs at least once a month is seen in 2% to 3% of the general population. 40-79 Rome 4 Consensus Conference criteria for functional vomiting include one or more episodes of vomiting per week for 3 months, with the onset of symptoms at least 6 months prior to diagnosis and with symptoms that are not cyclical in nature. 40 Eating disorders, rumination, self-induced vomiting, major psychiatric disorders, chronic cannabinoid use, and other structural or organic causes of vomiting should be excluded first. Psychosocial stressors and underlying depression or anxiety often play important roles and should be addressed. 40-80 Prevailing hypotheses regarding the pathophysiology of functional vomiting involve visceral hypersensitivity, altered gut-brain interactions, motility disturbances, altered gut microbiota or mucosal immune function, and psychosocial stressors. The lack of biochemical markers or anatomic abnormalities poses a diagnostic challenge. Evaluation includes a comprehensive history, and diagnostic testing to exclude organic causes of vomiting. EGD, contrast radiography, UGIS and small bowel follow-through, and cross-sectional imaging, e.g., CT, MRI, should be performed when indicated to rule out structural or obstructive processes. Tests assessing motor function, e.g., radionuclide gastric emptying study, Intraduodenal manometry may reveal findings suggestive of gastroparesis or intestinal pseudo-obstruction, although delayed gastric emptying can be seen in conjunction with functional dyspepsia, which can also be associated with nausea and vomiting, as well as other causes of nausea and vomiting, e.g., CVS, medication-induced nausea and vomiting. Intraduodenal manometry can differentiate mechanical from functional obstructive processes, although it has a low diagnostic specificity. If manometry is performed in a patient with vomiting, the diagnosis of intestinal pseudo-obstruction is essentially ruled out with the detection of strong antral phasic waves and a normal intestinal pressure pattern during fasting and postprandial periods. 81,82 Cutaneous electrogastrography, EG, measures the pacemaking ability of the stomach and can identify gastric dysrhythmias. 81 but does not establish whether gastric dysrhythmias are the cause or consequence of nausea and vomiting. 82 Beyond avoiding triggering foods that worsen symptoms, specific dietary therapy adds little to management. Coexisting nutritional deficiencies and metabolic disturbances also need correction. Psychotherapy, behavioral therapy, and psychotropic agents are all used in practice, even in the absence of formal studies demonstrating their efficacy. Reassurance and a supportive physician-patient relationship are crucial in the management of functional vomiting. 83 Cyclic vomiting syndrome and cannabinoid hyperemesis syndrome. Cyclic vomiting syndrome (CVS) is characterized by clustered, recurrent episodes of vomiting in the absence of an alternative etiology. Although initially described in children, CVS is now known to occur in adults, with an estimated frequency of 1.9% to 2.3%. It is most common in white males. 84 Rome 4 criteria define CVS as the presence of stereotypical episodes of vomiting, acute in onset and a duration of less than 1 week, 3 or more discrete episodes in the prior year and 2 or more episodes in the past 6 months, each occurring at least 1 week apart, and the absence of vomiting between episodes. 40, 84, 85 A personal or family history of migraine is supportive of the diagnosis of CVS, particularly in children. 84, 86 Regular use of cannabinoids can be associated with a syndrome indistinguishable from CVS, termed cannabinoid hyperemesis syndrome, which resolves with cessation of cannabinoid use. See later. The characteristic clinical presentation consists of the acute onset of nausea and/or vomiting with associated abdominal pain, anorexia, and fatigue. Episodes can last for hours to days, with symptom-free intervals between episodes. Physical examination findings are usually nonspecific but may reflect dehydration. Patients often consult multiple healthcare providers over time and undergo an extensive laboratory and diagnostic workup including blood tests, endoscopy, cross-sectional imaging, and even exploratory surgery. 87 The differential diagnosis includes gastroenteritis, PUD, gallbladder disease, pancreatitis, pregnancy in a female patient, or an underlying metabolic or psychiatric disorder. In the pediatric age group, various mitochondrial, ion channel, and autonomic disorders have also been associated with intermittent episodes of vomiting and may have to be excluded. Similarly, food allergy, sensitivity to cow's milk, soy or egg white protein, or food intolerances, to chocolate, cheese, nuts, or monosodium glutamate, may manifest with vomiting spells and should be excluded. See Chapter 10. 87, 88 Abortive treatment is typically initiated during the prodrome, if present. Anti-migraine drugs, especially serotonin 5-HT1 agonists, e.g., sumatriptan, administered subcutaneously, transnasally, or orally, have been utilized. Conventional antiemetics and benzodiazepines, e.g., lorazepam, administered intravenously can be of value during the acute phase. Dehydration and metabolic complications may require admission to the hospital and for corrective measures. 87 Tricyclic antidepressants, e.g., amitriptyline, nortriptyline, imipramine, desipramine, are effective as prophylaxis in about 2/3 of both adults and children. 85, 89 Beta-adrenergic receptor antagonists, e.g., propranolol, have also been used for prophylaxis. Other agents reported anecdotally to help improve symptoms include serotonin reuptake inhibitors, cyproheptadine, naloxone, carnitine, valproic acid, and erythromycin. The psychological aspects of CVS require special consideration. Although 20% of adult patients with CVS have an overt anxiety disorder or other psychiatric disease, anticipatory anxiety prior to an episode is common and may precipitate episodes. Consequently, management of concurrent anxiety or depression can be of therapeutic value. 85,90 Cannabinoid hyperemesis syndrome. In a subset of patients with CVS, symptoms can be precipitated and exacerbated by chronic cannabis use, a variant termed cannabinoid hyperemesis syndrome, with symptom relief if there is sustained cessation of cannabis use. 91,92 Cannabinoid CB1 receptors are distributed in the brain as well as the GI system, whereas CB2 receptors are found in lymphoid tissue where they regulate immune function. 93,94 Stimulation of CB1 receptors by endogenous cannabinoids results in inhibition of the hypothalamo-pituitary-adrenal axis and sympathetic response to stressful stimuli and modulates gastric motility and sensation, among other roles. 93 Fatty acid amide hydrolase and monoacylglycerol lipase are responsible for degradation of endocannabinoids. One of the proposed hypotheses is that regular cannabis use leads to downregulation and desensitization of CB1 receptors, leading in turn to abdominal pain and intractable vomiting that resolves when the receptors regain their original sensitivity following abstinence from cannabinoids. 95 Genetic polymorphisms in endocannabinoid receptors may also play a role, although further research is needed. 96 The manifestations of cannabinoid hyperemesis syndrome are indistinguishable from those of CVS, with a similar onset, duration, and frequency of episodes. A history of regular cannabis use and relief of symptoms with abstinence from cannabinoids are hallmarks of the syndrome. 40 Ritualistic hot baths are reported by many affected persons, although this feature is not specific for cannabinoid hyperemesis syndrome and can be reported by patients with CVS in general. Symptoms consistently improve or resolve with total abstinence from cannabis use. 95 The liberalization of marijuana policies in the U.S. has led to an increase in emergency room visits for cannabis-related syndromes, including cannabinoid hyperemesis syndrome, particularly in states like Colorado, where the increase is higher in out-of-state visitors than residents of Colorado. 97 In conjunction with abstinence, abortive and prophylactic approaches similar to those for CVS are effective. 98 In addition, topical application of capsaicin cream to the abdominal wall and parenteral haloperidol administration have been reported anecdotally to abort episodes. 98,99 Superior mesenteric artery syndrome. Although some objective basis exists for superior mesenteric artery (SMA) syndrome, the diagnosis tends to be applied inappropriately to patients with functional vomiting or CVS, who then are unfortunately subjected to unnecessary surgery. 100 The SMA branches off the aorta at an acute angle, travels in the root of the mesentery, and crosses over the duodenum, usually just to the right of the midline. See Chapter 118. The angle between the aorta and the SMA can become more acute under certain circumstances: increased lordosis with a body cast, loss of muscle tone or weight, prolonged bed rest, leading to partial obstruction of the distal duodenum. 101 Symptoms include epigastric fullness and pressure after meals, nausea and vomiting, often bilious, and mid-abdominal pain that may improve in the prone or knee-chest position. The diagnosis is supported by imaging tests, UGIS or CT, that show dilatation and stasis proximal to the location of the SMA in the third portion of the duodenum. The appearance may be misleading, however, because duodenal dilatation may be caused by atony rather than mechanical obstruction. 100 Stasis proximal to the site of duodenal obstruction should be demonstrated on contrast studies and / or scintigraphic tests prior to corrective surgery to avoid overdiagnosis. Intraduodenal and small bowel manometry may demonstrate characteristic patterns that distinguish mechanical obstruction from a motility disorder. Relief of vomiting with feeding through an enteric catheter placed across the obstruction into the proximal jejunum supports the diagnosis. Precipitating factors should be corrected first whenever possible. Acute symptoms may resolve with gastric decompression and fluid replacement. Therefore, surgical correction should only be undertaken in well-investigated patients with chronic relapsing episodes of SMA syndrome. The surgical technique performed most commonly is a laparoscopic proximal duodenojejunectomy. A gastrojejunectomy may not be effective because the proximal duodenum is not decompressed by this approach. 102 Rumination syndrome. Rumination is a distinct and unique functional gastroduodenal disorder characterized by repetitive effortless regurgitation of small amounts of recently ingested food into the mouth, followed by rechewing and reswallowing or expulsion. See also Chapter 13.103. Although rumination resembles vomiting, it does not involve an integrated somatovisceral response coordinated by the emetic center. Characteristically, nausea and autonomic manifestations, e.g., hypersalivation, cutaneous vasoconstriction, sweating, that usually accompany vomiting are absent. Rumination typically begins during or immediately following a meal and may stop when the regurgitated material becomes noticeably acidic. Rumination is relatively common in infants, typically developing between 3 and 6 months of age. There is no apparent distress, and rumination may cease with distraction or sleep. Rumination occurs in adults of any age with equal gender distribution. 79 The clinical significance of rumination varies. Some otherwise healthy individuals ruminate frequently without considering the practice abnormal. Others, under pressure from family or friends, consult a healthcare provider, who may mistakenly interpret rumination as habitual vomiting, GERD, or gastroparesis, which delays diagnosis and definitive management. Some ruminators seek medical attention because of the concern that they are unable to control the process. Alternatively, rumination may be associated with heartburn, epigastric discomfort, and changes in bowel habits in patients who have concomitant GERD, functional dyspepsia, or IBS, respectively. Weight loss may occur and suggests a possible eating disorder. Rumination may be diagnosed clinically in most patients with careful history taking. Achalasia, other esophageal motility disorders, gastric outlet obstruction, and gastroparesis should be excluded. Detection of esophagitis on EGD does not exclude rumination. Combined UGI manometry with pH impedance testing may show sharp phasic pressure spikes, R waves, recorded in the antrum and duodenum on manometry, which correspond to abrupt increments in intra-abdominal pressure as the patient involuntarily or voluntarily forces subdiaphragmatic intragastric content toward the esophagus through a relaxed lower esophageal sphincter. High-resolution esophageal manometry and impedance testing after a meal may help distinguish rumination from other belching and regurgitation disorders. 104,105 Because rumination is a behavioral disorder, the coexistence of rumination with another functional disorder should be considered. See Chapter 44. The pathophysiology of rumination syndrome has only partially been elucidated. Rumination may reflect adaptation of the belch reflex. See Chapter 17. During the abrupt retrograde movement of gastric content, the gastroesophageal junction appears to move into the thorax, thereby creating a pseudohernia that facilitates opening of the lower esophageal sphincter. 106 A distinct subgroup of ruminators have reflux-related rumination with abdominogastric strain that is synchronized with transient lower esophageal sphincter relaxation occurring as part of a reflux episode. 107 Treatment of rumination involves several steps. Reassurance and careful explanation of the phenomenon may allow some patients to control rumination on their own. Behavior modification is the most effective therapy and may be accomplished by teaching the patient special diaphragmatic breathing techniques or with the help of biofeedback training, because rumination and diaphragmatic contraction cannot be performed simultaneously. 108 Patients trained to control their abdominothoracic muscles by viewing EMG recordings displayed on a monitor experienced a reduction in the frequency of rumination episodes after just 3 sessions. Patients with heartburn and endoscopic evidence of esophagitis should be treated with a PPI. Further pharmacologic treatment includes baclofen, up to 10 mg orally 3 times daily, a gamma-aminobutyric acid agonist that increases lower esophageal sphincter pressure and decreases the swallowing rate. 109 Evaluation. Acute vomiting. Evaluation of a patient with acute vomiting begins with a carefully taken history and physical examination that focuses on the patient's volume status and important causes of acute vomiting. An algorithm for management of the patient with acute vomiting is shown in Fig 15.2. A pregnancy test should be performed in all women of childbearing age. Routine blood studies should include a CBC, tests of kidney function, thyroid function tests, liver biochemical tests, electrolyte, glucose, serum amylase, and lipase levels, and in some cases, arterial blood gases to assess the patient's acid-base status. Medication and toxin levels are ordered when indicated. Imaging plain abdominal films, supine and upright, should be obtained. If the films suggest SBO, further testing to ascertain the cause of obstruction, including cross-sectional imaging and urgent surgical exploration when appropriate, should be undertaken, see Chapter 123. If plain abdominal films are negative, additional tests can be considered. EGD can evaluate for mucosal lesions, ulcers, neoplasia, and gastric outlet or duodenal obstruction. CT or MRI of the abdomen may demonstrate intra-abdominal inflammatory or infectious processes, e.g., appendicitis, diverticulitis, acute intestinal ischemia, obstruction, or pseudo-obstruction. US of the abdomen tends to be less revealing in this setting. MRI of the brain can be performed to look for a mass lesion or other neurologic mechanisms of vomiting. Additional tests. Further testing can include blood levels of drugs and toxins, specifically digoxin, opiates, theophylline, ethanol, and carbamazepine, cultures of blood or body fluids if an infection is suspected, analysis of cerebrospinal fluid following lumbar puncture, and serologic tests for viral hepatitis, if indicated. If appropriate, blood levels of cortisol, corticotropin-releasing factor, and catecholamines can be determined. Chronic vomiting. A detailed clinical history and careful physical examination are central to diagnosing functional dyspepsia, functional vomiting, CVS, and rumination syndrome. EGD and/or a UGIS are the tests of choice for partial gastric outlet obstruction and partial duodenal obstruction. Barium contrast radiography may suggest a diagnosis of achalasia, gastroparesis, or neoplasm. CT of the abdomen is particularly useful for identifying intestinal obstruction, intra-abdominal masses, and retroperitoneal pathology, and also provides information on the degree of bowel dilatation, bowel wall thickness, and a transition point in bowel lumen diameter that helps localize the obstruction. 110. By contrast, plain films of the abdomen are often unreliable, particularly in the presence of fluid-filled loops of bowel. Magnetic resonance enterography is an alternative to CT enterography and has the advantage of not exposing patients to radiation. 111. MRI of the brain is useful for diagnosis of CNS lesions that may cause vomiting, including slow-growing tumors, hydrocephalus, and inflammatory, vascular, and ischemic lesions. Motility studies are useful for evaluating motor disorders including gastroparesis and chronic intestinal pseudo-obstruction, which are relatively uncommon but important causes of nausea and vomiting. See chapters 50, 99, and 124. Esophageal manometry. Esophageal manometry, preferably high-resolution manometry, is used to assess esophageal motor activity. Patients with esophageal motility disorders such as achalasia and other spastic disorders may occasionally present with vomiting or regurgitation. See chapter 44. Measurement of gastric emptying. Radioscintigraphy is the preferred and most accurate method of assessing gastric emptying and should be performed over a 4-hour period for accurate assessment of gastric emptying. Ideally, dual markers, separating solids from liquids, should be used and the test performed with a dual-headed gamma camera. Symptoms of gastroparesis are primarily associated with delayed solid phase gastric emptying. 112. Alternative, but less precise, methods of assessing gastric emptying include 3-dimensional gastric US to assess emptying of a liquid meal and the 1,3-C breath test with octanoate acid, a fatty acid that is labeled with a stable isotope and incorporated into a test meal. 22,113. The rate at which 1,3-CO2 is exhaled reflects the rate of gastric emptying and subsequent duodenal absorption of the lipid marker, but the diagnostic reliability of this breath test is not firmly established. See chapter 50, .114 Other potential diagnostic modalities include the wireless motility capsule, MRI, and single photon emission CT. .113,115 Cutaneous electrogastrography egg with cutaneously placed electrodes identifies dysrhythmia, e.g., bradygastria or tachygastria, of the gastric pacemaker and changes in the frequency of pacemaker activity in response to feeding. Although non-invasive and rather simple, egg findings do not necessarily correlate with clinical symptoms 54,81 and some egg findings may be secondary to rather than the cause of nausea. See Chapter 50. Antraduodenal manometry. Antraduodenal manometry is the most specific physiologic test for assessing foregut motor disturbances distal to the esophagus. Intraluminal pressure changes are recorded in the antrum and proximal small bowel using a pressure-sensitive catheter. The test is cumbersome, expensive, technically challenging to perform, and available at only a few centers that specialize in GI motility disorders. Manometry may distinguish myogenic from neurogenic forms of pseudo-obstruction and may help detect partial SBO on the basis of wave pattern analysis. See Chapters 50, 123, and 124. If antraduodenal manometry is abnormal, a laparoscopic full-thickness biopsy of the small bowel can be considered to diagnose genetic and acquired myogenic or neurologic causes of chronic intestinal pseudo-obstruction. Autonomic function tests. Tests of autonomic function can assess sympathetic function and include the tilt table test, an orthostatic challenge to blood pressure and cardiac rate regulation, and the cold hand test, a pain reflex test in which the hand is immersed in cold water to produce vasoconstriction and a significant increase in systolic arterial pressure. Parasympathetic function can be assessed by measuring variations in the RR interval on the electrocardiogram in response to bradycardia induced by deep respiration, via a vasovagal reflex, and by a voluntary Valsalva maneuver. Results of such tests can help distinguish visceral autonomic neuropathies, e.g., due to amyloidosis or diabetes mellitus, from a central autonomic disorder, e.g., Schiedreger syndrome, pandysautonomia. Histopathologic studies. In some patients, a further diagnostic step may involve histopathologic examination of mucosal biopsies for quantification of nerve density and morphology as evidence of autonomic neuropathy. 116 Complications. Vomiting, particularly when protracted or recurrent, can lead to a number of potentially life-threatening complications. Emetic injuries to the esophagus and stomach. Chronic protracted vomiting often produces esophagitis, ranging from mild erythema to erosions and ulcerations on endoscopy. Characteristically, esophagitis from vomiting extends uniformly throughout the esophageal body, in contrast to the distal esophagitis associated with GERD. Patients can experience heartburn or retrosternal pain after an acute bout of vomiting. By contrast, patients with chronic vomiting rarely complain of chest symptoms, and esophagitis associated with long-standing vomiting is often asymptomatic. Abrupt retching or vomiting episodes may also induce longitudinal mucosal and, rarely, transmural lacerations at the level of the gastroesophageal junction. Acute bleeding and hematemesis associated with mucosal lacerations at the gastroesophageal junction constitute the Mallory-Weiss syndrome. See Chapters 20 and 45. Bauer-Haff syndrome refers to spontaneous rupture of the esophageal wall, with free perforation and secondary mediastinitis and carries a high mortality rate. 117 It is more common in alcoholics, although esophageal rupture may develop in any person during vomiting. See Chapter 45. Multiple purpuric lesions may appear on the face and upper neck after prolonged episodes of vomiting, probably because of repetitive increases in intrathoracic pressure and rupture of blood vessels. Dental caries and erosions may result from chronic vomiting. Spasm of the glottis and aspiration pneumonia. Spasm of the glottis and transient asphyxia may develop during vomiting as a result of irritation of the pharynx by acidic or bilious material. Similarly, vomiting during insertion of an NG tube, during sedated endoscopy, in an older person, or when the cough reflex is depressed may result in aspiration of gastric contents into the bronchi, with resulting acute asphyxia and a subsequent risk of aspiration pneumonia. Aspiration is more likely to occur when the stomach contains food, fluid, or enteric secretions, which should be aspirated out from the stomach during endoscopy. Fluid, electrolyte, and metabolic alterations. Fluid, electrolyte, and metabolic abnormalities may develop rapidly after protracted vomiting. Dehydration, hypotension, hemoconcentration, oliguria, muscle weakness, and cardiac arrhythmias can result. Hypochloremic alkalosis is usually the first metabolic abnormality to develop and is due to loss of fluid, as well as of hydrogen and chloride ions. Hypokalemia results from loss of potassium ions in the vomitus and renal potassium wasting due to alkalosis. Hyponatremia may occur in severe cases because of loss of sodium and release of antidiuretic hormone in an attempt to conserve intravascular volume. Metabolic derangements, especially metabolic alkalosis with low urinary sodium excretion, may be a sign of chronic functional or self-induced vomiting. Nutritional deficiencies. Nutritional deficiencies may result from reduced caloric intake or loss of nutrients in the vomitus. Regardless of cause, chronic nausea and vomiting can result in malnutrition, weight loss, and deficiency states that require supplementation. See chapters 5 and 6. Treatment. Effective management of the patient with nausea and vomiting requires correction of clinically relevant metabolic complications, pharmacologic therapy, and treatment of the underlying cause. Correction of metabolic complications. Patients with acute, severe, or repeated vomiting may become dehydrated rapidly and develop metabolic imbalances, secondary circulatory collapse, and kidney failure. If oral hydration is not adequate, 4 fluids and electrolytes should be administered promptly. Adequate replacement generally consists of a normal saline solution in volumes sufficient to correct deficits, and in addition to maintenance fluids, with potassium supplementation, 60 to 80 milliequivalent / 24 hours. The normal saline can be administered with glucose, e.g., 5% dextrose in normal saline. In some cases a 10% glucose solution may be required. When oral intake can be resumed, glucose-containing fluids are preferred because they are easily absorbed from the intestine. A split meal, low-fat, and low-fiber solid diet can be gradually introduced. Patients with long-standing chronic vomiting are at risk of developing malnutrition, so enteral or parenteral feeding should be considered when the patient is unable to resume adequate oral nutrition after 5 to 8 days. Although enteral nutrition is a good option, even orogastrojejunal catheters placed with guide wires may be dislodged during episodes of vomiting. For long-term treatment, percutaneous enteral feeding tubes or home parenteral nutrition may be required. See Chapter 6. Pharmacologic treatment. Drugs used to treat nausea and vomiting belong to one of 2 main categories: centrally acting antiemetic agents and peripherally acting prokinetic agents. Some drugs share both mechanisms of action, with variable predominance of one or the other. Doses indicated are for adult patients. Table 15.1. Central antiemetic agents. Central antiemetic agents are classified according to the predominant receptor on which the drug acts. These can be administered orally, parenterally, single bolus, repeat boluses, or continuous 4 infusion, or transdermally when available. 118 Dopamine D2 receptor antagonists. Benzamides. The main antiemetic effect of benzamides, e.g., metoclopramide, clebopride, is through antagonism of the dopamine D2 receptor in the brainstem. These agents also stimulate peripheral 5-HT4 receptors, thereby facilitating acetylcholine release for intraduodenal prokinetic activity. Side effects limit the use of these drugs. When administered rapidly by the 4 route, metoclopramide may cause acute restlessness and anxiety. Repeated oral administration may induce somnolence in some patients. In about 1% of treated patients, distressing extrapyramidal effects, including dystonic reactions and tremor, may appear and limit their use, particularly at high doses. Older patients are at particular risk of tardive dyskinesia. 119 Metoclopramide may prolong the QT interval and thus has an arrhythmogenic potential. This agent is subject to tachyphylaxis and may lose efficacy with continued use. The most common indications for these drugs are nausea and vomiting of pregnancy, postoperative nausea and vomiting, and chemotherapy and radiotherapy-induced nausea and vomiting. Because of their associated gastric prokinetic action, the drugs can be used for gastroparesis related to diabetes mellitus, prior vagotomy, and prior partial gastrectomy. The standard dose of metoclopramide is 10 to 20 mg 3 or 4 times daily orally or intravenously. Benzimidazole derivatives. Domperidone is the main benzimidazole derivative but is not available in the USA. 120 The drug crosses the blood-brain barrier poorly and acts primarily as a peripheral dopamine D2 receptor antagonist. It blocks the receptors centrally in the area postrema, which is partly outside the blood-brain barrier, and in the stomach, where D2 receptor inhibition decreases proximal gastric relaxation and facilitates gastric emptying. Although domperidone is a weaker antiemetic than metoclopramide, it may be particularly useful for the management of nausea and vomiting associated with treatment with levodopa in patients with Parkinson's disease, because it antagonizes the proemetic side effects of levodopa without interfering with anti-Parkinsonian action in brain centers protected by the blood-brain barrier. The standard dose is 10 to 20 mg 3 or 4 times daily orally. A review of domperidone use in the treatment of diabetic gastroparesis has concluded that the drug is probably useful but has not been properly evaluated by well-designed controlled trials. Responses may be influenced by genetic characteristics. 121 Domperidone, as well as benzamides, may increase the release of prolactin and is occasionally associated with breast tenderness and galactorrhea. Domperidone has also been noted to prolong the QT interval and therefore has arrhythmogenic potential. Phenothiazines and butyrophenones. The phenothiazines, chlorpromazine, perfenazine, prochlorperazine, promethazine, and thiethylperazine, and butyrophenones, droperidol and haloperidol, also block D2 dopaminergic receptors in addition to muscarinic M1 receptors. Phenothiazines also block histamine H1 receptors. These drugs tend to induce relaxation and somnolence and are generally used parenterally or as suppositories in patients with acute intense vomiting of central origin, as in vertigo, migraine headaches, and motion sickness. They are also useful for patients with vomiting from toxic agents, from chemotherapy, and after surgery. 122,123 Safety concerns, especially extrapyramidal effects, have limited the use of all these agents to some degree. 124 For this reason, the dose of droperidol should not exceed 1 mg. Olanzapine, a second-generation neuroleptic agent, is an attractive alternative because of its strong anti-nausea and antiemetic action and lack of extrapyramidal side effects. 125,126 Side effects of the use of olanzapine include mild sedation, weight gain, and increased risk of diabetes mellitus. A double-blind trial that compared olanzapine, 10 mg, with placebo, both in combination with dexamethasone, oral aprepitant, or 4-fosaprepitant and a 5-HT3 receptor antagonist demonstrated a clinically significant reduction in chemotherapy-induced nausea and vomiting, with benefits extending up to 120 hours after administration. Patients who received olanzapine had significantly increased sedation, which was severe in 5% of cases, particularly at day 2 as compared with baseline. These symptoms improved by days 3 to 5 despite continued use of oral olanzapine. Olanzapine therefore may also be used in combination with other agents like dexamethasone or an NK1 antagonist. Antihistamines and antimuscarinic agents. Antihistamines and antimuscarinic agents act primarily by blocking histamine H1 receptors, cyclizine, dimenhydramine, cinnarizine, meclizine, hydroxyzine, and muscarinic M1 receptors, scopolamine, which may be applied transdermally, at a central level. 127 Scopolamine may induce annoying visual accommodation disturbances. 128 Although promethazines belong to the phenothiazine class, they also act as antihistaminic H1 and antimuscarinic agents with strong sedative properties. Cyclizine and diphenhydrinate are commonly used to treat motion sickness and have been shown to decrease gastric dysrhythmia, so their antiemetic effect may be mediated in part by their peripheral action. A standard antiemetic dose of cyclizine is 50 mg given 3 times daily orally or 100 mg as a suppository. The main indication is nausea and vomiting associated with motion sickness and vestibular disease. Cyclizine is useful for postoperative and other forms of acute vomiting. Some of these drugs are also used as antipruritic agents. Drowsiness is the major limiting side effect, particularly with older agents, but this effect may be advantageous in the treatment of acute vomiting. Anticholinergic effects. Table 15.1 Centrally and peripherally acting agents useful in the management of nausea and vomiting. * Drug category indications. Dose. Side effects. Centrally acting antiemetic agents: metoclopramide, clebopride, benzamides, dopamine D2 antagonist, peripheral 5-HT4 agonist. Nausea and vomiting of pregnancy. Postoperative nausea and vomiting. Chemotherapy and radiotherapy induced nausea and vomiting. Nausea and vomiting related to gastroparesis. 10 mg PO 4 times daily, 25 mg PO 3 times daily. Restlessness, anxiety, dystonic reactions and tremor. Tardive dyskinesia. QT prolongation. Chlorpromazine, perfenazine, prochlorperazine, promethazine, thiethylperazine, phenothiazines, dopamine D2 antagonist, muscarinic M1 antagonist, histamine H1 antagonist. Vertigo, migraines, motion sickness. Chemotherapy or postoperative nausea and vomiting. 10 to 25 mg PO every 4 to 6 hr, 8 to 16 mg PO daily, 2.5 to 10 mg for every 4 hr, 12.5 to 25 mg for every 4 to 6 hr, 10 mg for every 8 hr. Extrapyramidal effects. Droperidol, haloperidol, butyrophenones, dopamine D2 antagonist, muscarinic M1 antagonist. 2.5 mg for once 1 mg for every 6 hr. Diphenhydramine, cinnarizine, meclizine, hydroxyzine, histamine H1 antagonist. Motion sickness and / or vestibular disease. Additional antipruritic effect. 25 to 50 mg PO every 6 to 8 hr, 25 to 75 mg PO every 8 hr, 25 to 50 mg PO every 24 hr, 25 to 100 mg IM every 24 hr. Drowsiness. Anticholinergic effects on dansitron, granisetron, delastron, tropisitron 5-HT3 antagonist. Postoperative, chemotherapy, and radiotherapy induced nausea and vomiting. 0.15 mg/kg for every 8 hr, 12 to 24 mg PO every 8 hr, 100 mg PO 1 hr before chemotherapy, or 12.5 mg for 15 min before cessation of anesthesia, 5 mg for before chemotherapy, then 5 mg PO daily for 5 days. Headache. Dexamethasone, glucocorticoid. Postoperative, chemotherapy, and radiotherapy induced nausea and vomiting. 8 to 20 mg for every 6 hr, 4 mg PO every 6 hr. Hyperglycemia, worsening of PUD, and gastritis. Nobulone, dronabinol, cannabinoid. Refractory chemotherapy induced nausea and vomiting. 1 to 2 mg PO every 12 hr, 2.5 to 10 mg PO every 6 to 8 hr. Hypotension. Psychotropic reactions. Aprepitant, fosaprepitant, neurokinin 1 antagonist. Chemotherapy induced nausea and vomiting. Postoperative nausea and vomiting. 40 mg PO within 3 hr of anesthesia, 130 mg for 30 min before chemotherapy. Fatigue. Neutropenia. Peripherally acting prokinetic agents: prucalopride, cimetaprid, erythromycin. Peripheral 5-HT4 agonist, Modulin agonist. Nausea and vomiting related to gastroparesis. Nausea and vomiting related to gastroparesis. mg PO every 24 hr, 1 mg PO every 8 hr, mg/kg for every 8 hr. Cardiac arrhythmias. QT prolongation. * Agents used commonly in practice. Additional drugs are discussed in the text. Adult doses. HT, hydroxytryptamine, are potentially troublesome in patients with glaucoma, prostatic hyperplasia, and asthma. Serotonin antagonists. Serotonin 5-HT3 receptor antagonists, ondansetron, granisetron, delastron, tropisitron, are potent antiemetics that selectively block 5-HT3 receptors in the brain stem and in gastric wall receptors that relay afferent emetic impulses through the vagus nerve. In addition to their antiemetic effect, they have a modest gastric prokinetic action. The main indication for this class of drugs is nausea and vomiting associated with chemotherapy and radiation therapy or following surgery. They are often prescribed in combination therapy with haloperidol and dexamethasone, with or without an NK1 antagonist. 129 Headache is a common side effect. Ondansetron appears to be safe in pregnancy. It may be given as a single dose of 8 to 32 mg, intravenously in a dose of 0.15 mg/kg every 8 hours, or orally in a dose of 12 to 24 mg every 24 hours in 3 divided doses. There is a risk of QT prolongation with high doses of ondansetron. 0.130 granisetron is available in a transdermal patch form. 0.131 palonostrand, a second-generation agent, exhibits unique interactions with the 5-HT3 receptor and appears to be more effective than first-generation 5-HT3 receptor antagonists. It is the only effective agent for preventing delayed nausea and vomiting. 132-136 Glucocorticoids. The antiemetic mechanism of glucocorticoids is not well understood and may relate to inhibition of central prostaglandin synthesis, release of endorphins, or altered synthesis or release of serotonin. The principal indication is treatment of nausea and vomiting in the postoperative period or as a result of chemotherapy or radiation. Glucocorticoids may also be used to reduce cerebral edema and alleviate vomiting due to increased intracranial pressure. Dexamethasone is the formulation used acutely, in doses ranging from 8 to 20 mg intravenously and 4 mg every 6 hours orally. Side effects are uncommon because treatment is usually administered for short periods. In diabetic patients, however, careful monitoring of blood glucose levels is required. In patients with a history of peptic ulcer or with a gastroenteric anastomosis, concurrent administration of a gastric anti-secretory agent is advisable. In practice, dexamethasone is often used in combination with another antiemetic agent, such as haloperidol, olanzapine, metoclopramide, or a 5-HT3 antagonist. 137 Cannabinoids. Although cannabinoids cause or exacerbate nausea and vomiting, e.g., CVS, cannabinoid hyperemesis syndrome, cannabinoid agents have demonstrated utility in managing some forms of chronic nausea and vomiting. The benefits of cannabinoids are limited to patients with chronic nausea and vomiting. By contrast, intermittent stereotypical nausea and vomiting may develop from cannabinoid use and has a high likelihood of being part of a migrainoid disorder that may worsen with continued cannabinoid use. 2 oral synthetic cannabinoids are part of the standard therapeutic armamentarium, nobulone and dronabinol. Both agents are approved by the FDA for use in chemotherapy-induced nausea and vomiting refractory to conventional antiemetic therapy. The combination of a dopamine antagonist and a cannabinoid may be particularly effective in preventing nausea that has a major negative impact on a patient's quality of life. 138-139 Mood-enhancing properties make cannabinoids attractive to patients, but these drugs are potentially more toxic than conventional antiemetic agents. Hypotension and psychotropic reactions are relatively common side effects. These drugs should be used with caution in older adults and in patients with a history of mental illness. Cannabinoids are no longer first-line agents in the management of chemotherapy-induced emesis because of their side effects and the availability of more attractive alternatives, although they remain useful for breakthrough nausea and vomiting. 140 Neurokinin 1 receptor antagonists. NK1 receptor antagonists, which inhibit substance P and NK1, are potent antiemetic agents. 2 formulations are available, aprepitant, oral, and fosaprepitant, parenteral. Other preparations, e.g., rolapitant, are undergoing evaluation. 141-142 These drugs provide better protection against postoperative vomiting but not nausea when compared with 5-HT3 antagonists. NK1 receptor antagonists may be particularly useful when combined with other drugs like 5-HT3 antagonists and dexamethasone and are approved by the FDA for use in preventing vomiting in patients undergoing cancer chemotherapy. 129 Adjuvant agents and therapies. Patients with acute nausea and vomiting associated with chemotherapy, radiotherapy, and surgery often have anxiety that may exacerbate their symptoms. The anxiolytic effects of benzodiazepines, e.g., lorazepam, alprazolam, may potentiate the antiemetic action of agents like 5-HT3 receptor antagonists and glucocorticoids that are devoid of psychotropic effects. Gabapentin may help prevent delayed nausea and vomiting after chemotherapy. 143 Ginger has shown some useful anti-nausea effects. 144 Acupuncture, accustomulation, aromatherapy, and acupressure have also been shown to decrease the nausea associated with motion sickness induced by illusory self-motion and nausea associated with cancer radiotherapy and chemotherapy, but the evidence is somewhat controversial. 145-146 Gastric prokinetic agents. Serotonin 5-HT4 receptor agonists. Drugs in the Benzamide class share the peripheral 5-HT4 agonist effect of metoclopramide, also a benzamide, without the dopamine D2 antagonist action that is primarily responsible for the potentially troublesome central side effects of metoclopramide. Prucalopride, an agent primarily intended for treatment of constipation but with some prokinetic effects in the UGI tract as well, can be used in this regard. See Chapter 19. 147. Cimetaprid is another agent with pharmacodynamic properties similar to those of cisapride, an older drug that was associated with cardiac arrhythmias and withdrawn from the market. At a dose of 1 mg orally 3 times daily, cimetaprid appears to be free of cardiac side effects but is not yet available in the USA. The main indication for 5-HT4 agonist drugs is the management of nausea and vomiting associated with gastroparesis, intestinal pseudoobstruction, and functional dyspepsia. Motilin receptor agonists. Motilin receptor agonists include the antibiotic erythromycin and other agents, none of which is commonly available, that act as motilin receptor ligands on smooth muscle cells and enteric nerves. The pharmacodynamic effects in humans are dose-dependent. In low doses, 0.5 to 1 mg/kg as in 4 bolus, erythromycin induces sweeping gastric and intestinal peristaltic motor activity that resembles phase 3 of the interdigestive migrating motor complex but may empty the stomach inefficiently. See chapters 50 and 99. In higher doses, 3 mg/kg every 8 hours given as a slow 4 infusion, enteral activity becomes intense and empties the stomach rapidly, although the burst of motility does not always migrate down the small intestine. A simultaneous increase in small bowel contractions may induce abdominal cramps and diarrhea. When used clinically as an antibiotic, generally at higher doses, erythromycin may cause nausea and vomiting. In clinical practice, erythromycin may be used to treat acute nausea and vomiting associated with gastroparesis, diabetic, post-surgical, or idiopathic, and to clear the stomach of retained food, secretions, and blood prior to EGD. See Chapter 20. Although the prokinetic effect is well established, its symptom-relieving effects have been questioned. There is evidence that erythromycin modulates vagal nerve traffic, a potential anti-nausea mechanism. 148,149 Erythromycin may be administered intravenously in boluses of 200 to 400 mg every 4 to 5 hours. The lower doses are more appropriate for patients with pseudoobstruction, which is associated with reduced interdigestive sweeping motor activity in the small bowel. Erythromycin is not suitable for prolonged treatment, first because of relatively prompt tachyphylaxis and second because its efficacy by the oral route is uncertain and its inherent antibiotic properties carry the potential risk of complications, including pseudomembranous colitis and QT prolongation. Azithromycin, a structurally similar drug, has been proposed for the treatment of gastroparesis in slowly administered 4 boluses of 250 or 500 mg, but an FDA warning has alerted the public of the potential danger of azithromycin use in patients with heart disease. 150 New synthetic motilin agonists devoid of antibiotic activity are in development. Ghrelin is a peptide structurally and functionally related to motilin that acts to accelerate postprandial gastric emptying. Ghrelin receptor agonists, e.g., ulamorlin, adilmolin, mitomycinol, have prokinetic action and may have a future therapeutic role as prokinetic agents to treat nausea and vomiting in patients with gastroparesis. 151,152 Gastric electrical stimulation. There are 2 main technical approaches to gastric electrical stimulation. The first is low-frequency/high-energy stimulation, gastric pacing, that involves application of high-energy currents to entrain the gastric slow waves and generate phasic contractions. This technique may achieve correction of gastroparesis and amelioration of nausea and vomiting but requires external energy sources that limit the autonomy of the patient. A technical variation, 2-channel gastric pacing, has achieved some success in normalizing gastric dysrhythmia and delayed emptying. 153 A second approach, gastric neurostimulation, delivers high-frequency/low-energy impulses to the stomach with the use of an implantable neurostimulator, Intera system, similar to devices used to control chronic pain. The gastric neurostimulator does not entrain slow-wave activity and does not consistently accelerate emptying, but it appears to relax proximal gastric tone, reduce discomfort associated with gastric distension, and produce significant improvement in nausea and vomiting, as well as the patient's nutritional status and quality of life, even in patients with normal gastric emptying. 154-156 in responders, symptoms may be ameliorated for at least 5 years, on average. 157 Addition of a pyloroplasty has been proposed to boost the effectiveness of neurostimulation in patients with nausea and vomiting associated with gastroparesis. 158 Gastric neurostimulation is not without risk. Commonly reported complications include electrode dislodgement, infection, and bowel obstruction. 155 The device is also expensive and may be recommended with caution only for long-standing, at least 1 year's duration, refractory gastroparesis. A trial of temporary neurostimulation via endoscopically placed electrodes is feasible. 159 Acknowledgement. The authors acknowledge the contributions of Drs. Juan R. Malagellata and Carolina Malagellata to this chapter in previous editions of the book. Full references for this chapter can be found on vexpertconsult.com.